You know, whenever you or someone you love needs medical care, there's always that one big question hanging in the air. Will it work? Is this treatment going to be a success? But what does success in medicine actually mean? Well, the answer is a lot more complicated and, honestly, a lot more important than you might think.
I mean, really think about it. If your doctor suggests surgery, what's the goal? Is success just, surviving the operation? Is it being totally cured of whatever the disease was? Or is it something else, something more personal? This very question is at the absolute heart of a huge field of medical science.
And that field has a name. It's called outcomes research. This isn't just about what happens inside the hospital walls. It's all about understanding the real-world results that actually matter to patients. Things like your ability to get back to your daily life, your quality of life, and yeah, of course, survival too. It's the science of measuring what we all truly care about at the end of the day.
Now, to get their heads around all this complexity, experts use this really elegant, simple framework to think about the quality of medical care.
It's called the Dunabedian model, and it's actually super intuitive. Just think of it like judging a restaurant. First, you have the structure. That's the kitchen itself, the hospital, the fancy equipment, how well the staff is trained. Then, you've got the process. That's the recipe, the specific tests they run, the procedures they follow. But the most important part, right? It's the outcomes. How did the food actually taste? In medicine, that's the effect the care actually had on the patient.
So, out of those three, outcomes seem like the big one, don't they? And you'd think the most obvious, most straightforward outcome of all would be survival. But, and this is where it gets really interesting, even a number that seems that simple can be incredibly deceptive.
I mean, on the surface, it seems so black and white. A patient is either alive or they're not. There's no gray area. But when we start using survival rates to judge how good a treatment or a screening test is, we can fall into some pretty serious statistical traps.
Okay, so trap number one is called lead time bias. This one is tricky. It's this illusion that gets created when a screening test, like a mammogram or a PSA test, finds a disease earlier. It makes it look like the person survived for a longer time after they were diagnosed, even if the treatment didn't actually push back their date of death by a single day.
And this diagram here just lays it out perfectly. Look at that top bar. No screening. The patient lives for 5 years after diagnosis. Simple enough. Now the middle bar, a screening test finds the cancer 10 years earlier. Suddenly, their survival looks like it's 15 years long. But here's the kicker. They still die at the exact same age. It's only in that bottom bar, where the screening actually leads to a better treatment, that life is genuinely extended.
All right, next up we have length time bias. The basic idea here is that screening tests are just naturally better at catching the slow-moving targets. They're great at finding those less aggressive, slower-growing tumors that, frankly, might not have been the ones that were going to cause a problem anyway.
And you can see that so clearly right here. That vertical line is the screening test. See those long arrows? Those are the slow-growing cancers. They have this huge window of time where they can be detected. But the really nasty, fast-growing ones, the short arrows, they might just pop up and cause symptoms in between screenings. So, screening naturally finds more of the good cancers, which can inflate how effective we think it is.
And the final big headache is something called attribution bias. This is a real whodunit. When a patient who has a serious disease dies, what was the actual cause? If a cancer patient has a fatal heart attack, was that a side effect of the harsh treatment, or was it totally unrelated? It is often incredibly hard to tell for sure. And check this out. One study looked at patients who died within a month of having prostate cancer surgery. A whopping 75% of those deaths were officially attributed to causes other than the cancer itself. So what's the takeaway? Our data is only as good as our ability to connect the right cause to the right effect.
So all of these biases really show the limits of just looking at cold, hard, clinical data, like mortality. So if that's not the whole picture, where do we turn? Well, increasingly, the answer is to go straight to the source, the patient.
And this quote tells you exactly why that's so critical. Study after study has shown this massive disconnect. When you compare how a doctor rates a patient's symptoms to what the patient themselves says, doctors consistently and significantly underestimate how bad the problems really are.
This has led to the rise of what we call patient-reported outcomes, or PROs for short. Think of these as scientifically designed questionnaires that let us capture a patient's health status, their symptoms, how well they can function, their overall well-being, directly from their perspective. There's no filter, no interpretation from a doctor, it's their voice.
But hold on, you can't just throw any old questions at a patient and call it science. To be useful, these tools have to be rigorously tested for two key things. First, they have to be reliable, meaning do they give you consistent results time after time? And second, they have to be valid, meaning are they actually measuring the right thing?
And trust me, making sure a questionnaire is both reliable and valid is a true science. Researchers put them through the ringer. They test for everything, like, do the questions even make sense to patients? That's called face validity. Do you get roughly the same score if you take the test a week apart? That's test-retest reliability. Every single part is tested to make sure the data we get is solid and trustworthy.
Okay, so we've journeyed from just looking at survival to actually asking patients about their symptoms. But we can go one level deeper still, to ask what might be the ultimate question of all.
And that question gets at this idea of health-related quality of life. This goes way beyond just a list of symptoms. It's about a patient's own personal evaluation of how their health is affecting their entire life. One researcher brilliantly described it as the gap between a person's hopes and expectations and their actual present experience.
And it really boils down to these two pillars. Function is the objective part. What can you physically and mentally do? But bother, that's the crucial personal piece. It's how much those symptoms and limitations actually trouble you. I mean, two people can have the exact same physical problem, but a completely different quality of life depending on how much it bothers them.
So here's the bottom line. True medical success isn't just about what a lab test says or what a scan shows. It's about finding that balance. It's about combining that hard, objective data with the rich, subjective, and deeply personal experience of being a patient. That's the real scorecard.
And that leaves us with a really fascinating question to chew on. As we all start tracking our own health with smartwatches and apps, constantly generating our own data streams, how is that going to change the way we define and measure a successful outcome for ourselves? What will that scorecard look like tomorrow?